Awesome. Hi, everybody. Thank you so much for joining us. My name is India Williams. I lead operations here at Scale Health. I want to give just a huge thank you to you all for joining us for the final fourth webinar as a part of the IEHP Innovation Challenge. Today, the topic of conversation is all on family unit care. We'll have the opportunity to hear from representatives of the IEHP team to talk about how they view innovation and technology in this industry. Before we go ahead and kick it off, I am pleased to introduce you all to Jeff Pierce, who is the Director of Innovation and Acceleration at IEHP. Jeff, thank you so much for joining us.
Thanks, India. I'm glad to be here. And thank you everybody for joining. So just as a quick intro and background, Jeff Pierce, I'm privileged to be the Director of Innovation Acceleration here at IEHP. My role here, among other things, is to foster innovation, bring folks like yourselves together, as well as our internal thinking, industry thinking, together to build a repeatable discipline, right? We want to, as innovation suggests, we want to fail fast sometimes, learn, grow. We want to move towards quality of care and health outcomes for our members here at IEHP. So just a bit of background for those who may not already know. IEHP is a highly mission-driven organization to heal and inspire the human spirit. Pretty amazing mission, in my opinion. Launched in 1996. With only 62,000 Medi-Cal members. So since then, it's grown into the largest not-for-profit Medicare Medicaid plan in the country, with over 1.6 million members. And as this topic suggests, we are looking to everything we can to keep the members we have, as well as keep them with healthy outcomes. And we want to understand ways to grow. Over the past several years, IEHP is no stranger to innovation. We've been working on several different initiatives and programs, some of which very much related to what we're talking about today. Connecting care for members, as well as connecting members to available community resources. For example, behavioral health and how it connects to our complex care management. So think of that as kind of a whole person care or holistic health, as well as community health needs and navigation. So identifying top needs across at-risk population sets and providing health navigation and supporting them in connecting with their communities and their community resources available to them, whether that's rides to their office appointments, or it's clinics, or it's also access to proper food if in a food desert, for example. With this particular innovation challenge, we strive to continue our commitment in the path towards connecting the care that impacts our members, impacts their lives and health in a positive way. This is an opportunity to expand our foundational components, bring what we're already doing around whole person care, health equity, community care together, and bring it towards more of a family unit, as you'll hear more about, and you've likely read about in the assessments you've been working through. I'll leave you in the hands of the mediators in just a moment, including our Director of Quality Improvement, Tara Tokika. Before I do, I want to highlight a couple things related to our vision. One is, and our values, I should say. One is placing our members at the center of our universe. So I want everybody to be thinking, as I'm sure you already are, from a design-centered, user-centered design perspective, as well as a systems thinking perspective around our members. Also unleashing our creativity and courage to improve health and well-being. So with that, I'll pass it back to India and over to Kat.
Awesome. Thank you so much, Jeff. Before we go ahead and get started, I want to go ahead and just make a quick reference to utilize the chat if there are any comments, questions that come up as a part of this conversation or related to the challenge in general. I already see a question related to recording. We will be able to post that on the challenge website, so you can view that after this webinar takes place. So with that, I would love to welcome to the stage Kat Karimi, my colleague who leads partner success here at Scale Health. Kat, feel free to take it away.
Great. Thank you so much, India. And Jeff, thank you for your introductory words. I'm Kat Cramey. I head up Partner Success here at Scale Health. I've had the opportunity to moderate the 4 webinars related to the IEHP Innovation Challenge. And it's my privilege to moderate our last one today with the Director of Quality Improvement, Tara Tokika, I'm sorry. And we'll go ahead and launch into a series of questions to give everyone joining us today a better idea of what we mean by family unit care and why is this important, and what is IEHP looking for when working with innovators. So Tara, thank you so much for joining us this morning. First, I think it'd be great for everyone to understand who you are, what your role is at IEHP.
Yes, awesome. Thank you for, all of that great introductory information. Thank you, Jeff, for, just really sharing about IEHP and who we are as an organization. So I've been at IEHP for 11 years. So I haven't got to see all of that transition and transformation, right? When we went from, those so few members and now we're all the way up at 1.6 million, but have been here for some time. And I've had an opportunity to be in the quality team in some capacity, for the past 7 years. And, so now in the role of the quality improvement director, I really enjoy the opportunities that I have and the privilege that I have in collaborating with some really just amazing internal and external partners on the development and implementation and oversight of many of our quality improvement activities and initiatives that we have here at IEHP. The team does a really great job looking at information to help us recognize, where are some of those gaps and where are, some of those opportunities. And, while looking at achieving performance goals and metrics, is important, right? Because we want to be able to demonstrate to our regulators and our accrediting bodies that, this great work is happening. The real joy, I think, comes from knowing that the work we do in quality really does make a difference, right? It enhances the health and the wellness of our most vulnerable populations. Especially like when we're thinking about the Medicaid populations, many of them have complex health and, even social needs. So it really is, just a great honor and privilege to be in quality and to support the needs of our members.
Great. Thank you so much for that. And I must say, I just really enjoyed working with you and other members of the IEHP team. The vision and mission that Jeff spoke about earlier is truly ingrained in everyone I've had an opportunity to work with. So I think, just what you were saying right now is very consistent with everything that I've heard from other members of the team as well, which is truly fantastic. Specific to this category around family unit care, I know your role kind of spans beyond this space, but specific to family unit care, just so we're speaking all of the same language, can you help us define what you mean and IEHP means by family unit care?
Yeah, so in thinking about family unit care, I think this would be a healthcare approach that really addresses the needs of our members living in the same household. And when we say healthcare needs, this could also include, potentially barriers to care. Like, what are those barriers? And I would say specifically for this design challenge, when we talk about healthcare needs, that would be thinking specifically about some of those preventive health visits, right? So things like wellness visits, maybe immunization, some of those needed health screenings, as well as, chronic healthcare services. So, many members may have some chronic conditions. And so how do we, look at the family unit, to provide the healthcare that would be needed? And so that, again, could include organizing some of those services, helping to coordinate some of those services, and even, the delivery of that care. And so how do we make it more accessible when thinking about the entire family unit.
Understood. And so, given your role in quality and specific to this category, what keeps you up at night? Like what? Yeah, let's start there. What keeps you up at night?
Yeah, so great question. And so I would say in thinking about quality, right, and the work that we have here at our organization, so we mentioned we have 1.6 million members that we're working to support in a quality space, right? There's a lot of work that is currently in place to help our members really get the care that they need. And so for me, I would say what keeps me up at night is that even with all of that work, we're still not really meeting the goals, especially those that are being mandated by some of our regulators. And so, I know that we need to think differently about how to address some of those quality gaps, right? And so, mind is kind of always spinning, right? Like, what are we missing? What can we do different? What can we do better? And, just in thinking about that, some examples that would come to mind would be, maybe how do members want to utilize and access healthcare services? And, maybe why are some members not accessing those healthcare services, specifically those preventive care visits? And then, how can the role of the family unit really help us think differently about addressing some of those healthcare needs, and what might that look like?
So, and I'm gonna come back to, you mentioned some data, and I want to dive into that in just a moment. But what does it look like in your experience when family unit care is not leveraged? What does poor family unit care look like?
Yeah, so I would say some really good examples would be when you think about single transaction type communications, which is, I think, a lot of what is in place, not just for IEHP, but just thinking about a lot of the communication and outreach efforts that are currently in place to work to engage members with care, right? So if we think about what some of those could be, we have activities like inbound calls, right? So we're taking inbound calls from a member, we're making outbound calls for a member. We have texting campaigns, mailing campaigns. We have alerts that we can place on members' profile. So those are all ways, right, that we can communicate, healthcare gaps, needed healthcare services. However, it's very single member focused, right? So that outreach, when I make an outbound call, I'm working on a call list, and on that list is going to only be, let's say, members of the household that are child age and they need a wellness visit, right? There could be other members in that household that also, potentially have some care gaps, but we're not really organizing the efforts in that way to consider what a unified message for a family might look like. So I would say, of course, there's probably some rules, that are in place with some regulators that might limit the ability to share some information across a family unit, right? But that's why we're all here today, to think about how can we be innovative, right, about this. And, I would say, currently we don't really have like family-based strategies in place to really help support some of those quality measure performance goals, right? And so I think I can give an example if that would be helpful. I think I can give an example. There's probably something we see quite often.
Yeah.
So let's say a caregiver calls in to the health plan. Maybe they're calling because they needed a new IEHP ID card. Maybe they're calling, because they had a question about a referral, maybe they want to change their PCP. That engagement with the IEHP representative, again, is going to be very transactional based on that specific request. That parent may have some children in that household that have some care gaps, right? Maybe they're due for some immunizations. Maybe they're due, for some well child visits. However, the agent that's supporting that inquiry, they can't really see all of that detail unless the caregiver specifically asks about that child during the call. So again, the only then would a member service staff be able to look up that child's information and be able to confirm that there might be some services that are due. And, it's very likely that what could happen is we already have an outreach campaign. Maybe that child's included in that outreach campaign. And then the family is going to maybe get a call in the next few days reminding that that child is due. Maybe mom's busy at that time. She's not available to answer the phone, and so we really missed this great opportunity to be able to talk about the health and wellness needs of the entire family unit while we had that, that key player of the family, the caregiver, engaged with us. So I think that's a very common example that we would likely see.
Right. And you touched on something that I want to kind of double click on a little bit. So you spoke about some of the challenges of your current efforts, and what are some of the current strategies that are in place, and and why those may or may not be very as effective as they could be. So what does success look like to you?
Yeah, so great question. And so I would say success in thinking about specifically, this design challenge and, moving and continuing to expand what we learn from this design challenge. I would hope that we would be able to leverage really some insights about what families need most when interacting with the healthcare system. So, using the experience and the knowledge that we're, hopefully going to get through this process and this exercise to really develop some of those solutions. And then I think success specifically would be when we have found at least one new way of interacting with our families that really helps to close those care gaps and improves their experience, right? From their perspective, their experience with the healthcare system.
Understood. And I'm going to come back to where we spoke about the data earlier. I think I anticipate there's probably going to be some additional questions around this, but to the extent that you may be able to provide some lay of the land, are there any metrics around this particular pain point that you'd be able to share with the audience today?
Yeah, so I wish I had some better numbers, but honestly, I would say having data around this pain point is a current pain point. And that is really, we don't really have data available that gives us a clear picture of what that family unit looks like, right? So, I mean, I can give a couple examples. One, we do have a small, a little insight into some of the data. So for example, we have a way that we can connect newborns to their caregiver. So we call it internally, like a mom-baby link. But again, that would be, specifically for those newborns and moms. And we have a process in place. And, current state, we're probably only capturing about 60% of that newborn population, right? Meaning that only about 60% of those newborns are we able to link to like a parent or a caregiver? And I would say on the opposite end of the spectrum, right? So if you move to, let's say, older adults, right, who many may be getting care from children or other members of the family to support them as they continue to age. That component, we're really not able to clearly identify those members who do have a caregiver or do not have a caregiver. So I would say, as far as the numbers and the data in general, this is just a pain point overall.
I'm fascinated by the mom baby metric. And I don't know to what extent you have details around that, but it might actually be extrapolated across other parts of the population. Is that for? I'm trying to unpack why you think that is. Why is it that IEHP is only able to link 60% of mom babies, or is there a way that you guys have tried in the past to identify whether or not someone has a caregiver? Just trying to, maybe speak to some of the efforts or challenges that IEHP has faced in attempting to address this in the past.
Yeah, so that's a great question. And I think some of it is in the data, right? So when you think about just trying to do that link of mom and baby, that the information that's received on baby, baby may not have the same last name as the caregiver, or maybe they did at the hospital and it was maybe caregiver's last name, comma, baby boy or baby girl, but then that name evolves into something else. And so just having that's just one example, but there are different reasons, multiple reasons why potentially we would not have with very strong confidence, right, that mom and that baby are definitely linked. So that currently is kind of what we're looking at as far as being very confident, right, in the information that yes, this baby is connected and linked to this family or this mom. It's about 60%.
And then are there historically any other challenges that you can speak of? I know you've covered several already, but if there are any more that we didn't touch on that IEHP has historically faced in addressing this challenge?
Yeah, so I would say, again, just historically, those quality improvement initiatives have really been geared towards individuals within a family, right? So when we think about some of the initiatives that we develop, they tend to be more, let's say, population based, right? So we're going to develop an initiative and it's focused on adolescent immunizations, or maybe it's for supporting members that have uncontrolled hypertension, right? And so again, it becomes very individual within the family and not the family unit. So I think some of that just stems from some limited experience with some of those successful strategies around engaging families with the healthcare system. So when we were talking about what keeps us up at night, so again, just trying to really be thoughtful about stepping through this and what might this look like, because this is a new space for us here at IEHP, and thinking about it this way through the quality lens. And when we were talking about the data, again, we have some limitations because current state, we don't really have a clear profile of what that family unit might look like, right? I mean, we have lots of information, really good information on demographics. We have race, ethnicity, language, you know, regions where individuals live, and you know, and in addition to that, wouldn't it be really great if we could also identify, are these single individuals, right? Do they live alone? Is this a multi-generational household? You know, what does some of that makeup look like when you think about the family unit? And so really some of that additional like contextual knowledge and some of those insights, I think could be very valuable, right? As we think about how to continue to develop some of those quality strategies. And so, you know, just really having that clear understanding of the family as the consumer, and you know, what are those behaviors that could really influence you know, how they would like to access healthcare. You know, and I think that it's just been a challenge to decipher some of that. So I'm very excited about where we go from here.
Yeah, and thank you for that. I think that kind of historical lens of what has been attempted, where some of the challenges and pain points currently are, and addressing this topic is really helpful for our innovators to really hone in on where they can add value potentially. And you started to touch on it as well, and kind of what does success look like and what it is that you're looking to achieve. And so when we're looking at outcomes for the innovators to address around family unit care, what I heard was really how to identify what does that family unit look like, right? Who is in that family? Who's potentially the caregiver? So if you're speaking with the mother, they may be responsible for booking appointments for their underage children for their well care visits, but potentially also an older parent who needs to do kind of annual preventative care or chronic disease management. Those are the two that I heard as key objectives, right? That preventative care and chronic care management. Is that accurate?
Yes, absolutely. So, I mean, right on point. You know, just really thinking about those best ways to engage with those families. And I mean, you bring up a really good thought, Kat, which is, you know, specifically identifying who is that key caregiver in the household, right? And so how to engage with that family unit, specifically on those preventive care and, you know, potentially chronic healthcare services that might be needed. So just really thinking through tailored approaches, you know, based on that family demographic, specifically in the Inland Empire. You know, we have some really just unique challenges, I'll say, that we face in the Inland Empire. I mean, with San Bernardino and Riverside County, it's a massive land area. Some of our members, you know, they're in remote areas, and so, you know, again, just thinking about how to support, you know, some of those specific needs and how they might vary in different regions of the two counties that we serve.
And thanks for providing that background on the region. I want to be cognizant of the fact that not everyone is from Southern California on this call. Definitely have some folks from other parts of the country. So for everyone's awareness, San Bernardino, and please correct me if I misspeak here, but I believe San Bernardino and Riverside counties geographically are the largest counties in the country. Maybe not by population, but at least geographically. And it spans a considerable, to your point, demographics is very, very diverse. And so you have some of those remote, almost rural areas within the counties. And so access to healthcare, as we know, across these geographies can be very challenging. So thank you for providing that. I and remember that not everyone knows what we talk about Inland Empire, what we're really talking about here. Okay, so I think now just kind of going switching gears a little bit into the challenge, the assessments themselves for family unit care. So just for context, if the folks on the call here haven't already started the assessments for the Innovation Challenge, we'll make sure to post all of the links in the chat. But there is an assessment specific to the family unit care category, in addition to several other assessments that would be part of your overall submission. And so in thinking in that of the different kind of assessments, we have HIPAA, information security, business traction, and then we have a general IEHP one as well. What are some of your expectations when reviewing the submissions specific to this challenge?
Yeah, so great question. So of course, adhering to those regulatory requirements like HIPAA, are definitely top of the list. And then in addition to that, I would say, just really looking for those system level solutions and approaches that engage the family unit with those preventive care and chronic healthcare services. So I don't want to be too prescriptive, want to continue to give some of that leeway for the creative thinking. But I think, that's really kind of the key, right? So because we're doing so much already, like one at a time, I guess I'll say, right? When we talked about how we're doing all of those individual touches. And so, again, just trying to pull up, I guess, a layer maybe from that would be a way to describe it. And thinking about, again, some of those systems, meaning family unit, right, type solutions. So.
Okay, great. And anything that startups should be aware of when working with IEHP?
So, I mean, I think, we brought up kind of the diversity in the different regions, right? So I think that is definitely a good one. I think something else to just be mindful about is, IEHP does not directly employ our physicians to provide healthcare services, but we directly contract with them to deliver those care needs. So that's just, I would say a nuance to be aware of. And then, of course, Medicaid, Medi-Cal population is the focus of this solution. So, as we mentioned earlier, oftentimes the Medicaid population, they have multiple social determinants of health. Some of them, have very complex health needs as well, in addition. So just kind of thinking about that population specifically and what that might look like for them, for those families, when you consider access to care or accessing care, coordinating care. And then in addition, I would also say our member contact information has historically been a challenge, right? So again, in thinking about the Medi-Cal population, these are families that, sometimes they might not have stable housing. So there might be some moving around, and that contact information with their eligibility worker through the county might not always be updated timely. So just something to think about that has been a challenge. And also, I would say something that has compounded that when you think about contact information with the COVID pandemic, and we had those Medicaid redeterminations. They were on pause, right? Because we didn't want anyone to lose their healthcare coverage during that time. So it was not a requirement for them to be, for members to be filling out those updated packets to update all of that, address and contact information. So that has just recently restarted. So now we are, a few months into that redetermination process, and now families are being asked to fill out those Medicaid packets. So we're hoping, right, as we continue to progress through that, now that that pause has been lifted, that we'll start to see more of that contact information be updated. But, just wanted to share that as well.
That's a really good point. Our last webinar was on the member redetermination and retention, and that point didn't come up. I mean, we definitely spoke about, in the recent months going through that process, given that the emergency, the pandemic emergency plan had expired. But the fact that you essentially, in some cases, may have 3-year-old data.
Correct. That's correct.
So that definitely poses a challenge. Understood. Okay, thank you for pointing that out. I think that's important for everyone to understand as we think of the various hurdles that they may need to overcome or address around the contact information specifically. And so just want to be mindful of time. I see questions coming into the chat. One last thing, any final thoughts or advice for the participating companies?
So I would just say, oops, my lights went out in my office because it's motion censored. So sorry about that. I guess I haven't been moving enough to keep
You have
them
to
on.
wave your arms a little.
Yes, I have to wave my arms. So I'm going to stop my video just for a moment so you don't have to see my arms wave. Oh. Okay, give everyone a little commercial break there. Okay, good. So the video's recording. So I would just say like how excited we are about this opportunity, how hopeful we are about this opportunity. And, again, we're just really looking for some innovative and interesting ideas to really meet those family needs in ways that we haven't thought about or ways that we're not doing today. And so, again, just looking to find some of those unique solutions that can really, again, be tailored to meet the needs of those families residing in our Inland Empire areas who have that Medi-Cal coverage. And so I would also say, too, that we're looking for a project partner and a collaborator, right? So we don't want to hand off the work and say here, go do. We want to really be involved with the work and again just be a partner and an active collaborator, and hoping that we can have that opportunity to have that partner just engage directly with us and the IEHP teams to support that effort moving forward. And so again, just want to thank everyone for taking time to kind of hear about this design challenge. And again, I'm just so excited to kind of see what comes from this. So
appreciate your time, Tara. Thank you so much. We are going to reserve the last 15 minutes or so for the Q&A. And there may be I see some questions here that are specific to metrics. So understanding that you may not have those readily available, but to the extent that we can provide them at a later time for folks on the call, that would be great. But let's see, we're going through here. And India, if you don't mind, while we're going through the questions, to post the link to the IEHP Challenge, Innovation Challenge website, and any other materials that they may need to access previous webinars or the Scale Health portal. That'd be great.
Also, Kat, while you're teeing up some of the questions, just wanted to add on just some of what we're looking for and some of the expectations. And as Tara mentioned, I think perfectly, it is about partnership, and it's about, but I also wanted to add in, there's a there's a strong need for, as most of this suggests, it's about engagement, and it's about adoption of whatever solution, tool, process that is presented and brought forth as an idea. So I'm a big fan of ideas that bring gamification and/or any kind of something that brings the patients and the members and even the family unit to a stage of they may not even know they're getting healthcare. I think some of the best ways to engage folks is in a way that has them feel engaged perhaps with one another, but in reality, they're solving a lot of other problems. So I would hope to see some solutions that not only set the foundation for, in what we need and what you're hearing some of the constraints around connections with data and connections with family and preferences of how the unit might work together and their roles within the family unit. But also just around, some of the tools and technology that I think will help facilitate that. And just as a side note on lines of business also, while this is focused, yes, on quality and making sure that we're providing the best health outcomes and using our HEDIS measures and other measures put forth by NCQA and other agencies to support it. We're also wanting to make sure that we can hit the market where they are with other lines of business like Covered California. We also are going to have members that move from Medi-Cal, perhaps off Medi-Cal, back on, perhaps into Covered California. So I want people to keep that in mind, that there are multiple lines of business. We want a member engagement strategy to be seamless to the member.
Thanks for the additional information, Jeff. Yeah, there's a lot of considerations, especially and one of the questions that came up here is, how are you acknowledging that you may have members within a household that don't qualify for Medicaid, right? And so you have how do you engage with the member and the associated household that is an IEHP member with folks who are potentially not members in the same household. So there's when Tara was talking about the complexity of some of these family units, that's, I imagine, a consideration as well. And going in from IEHP to maybe an employer-based insurance, and then back to IEHP if they get let off, and things of that nature too. So just yeah, I can see how it gets rather complex.
Yeah, good point.
Okay, so one of the questions was around, are you able to share data on how many households you are solving for when you mentioned family unit care? Now, Jeff, you mentioned 1.6 million members. Do we have any sense of how many family units that comprises, or is that part of the data gap?
I don't have that data on the tip of my my tongue here, so I think we do have access to understand, how many members are in different households and what those family units, at least in general, look like. So I think that's something we can share, but we'll take that back to the team and see what kind of data we can pull forward and post.
Great. Let's see, how accessible are the members from a communications engagement perspective in order for members to get the care they need? Do most of them consistently connect, communicate, or engage with IEHP? If so, how? Is there an area of opportunity on engaging members? What would be the most valuable? So I think we touched on this in that, Tara, you mentioned the various modalities of engagement with your members, right? So letters, phone calls, outbound and inbound, email, text. I know just based on previous conversations with IEHP members, especially around redetermination, there's physical locations where people can go and get information directly from IEHP. But what I heard is is the challenge around the contact information specifically, that there's a willingness to engage, but maybe perhaps it's just not having a full contact list for individual members. Is there anything would you say that differently, or would you anything to add to that?
Yeah, no, so I think that was a great summary. I think the only thing that I would add, it would be to say, I think that's some of what we're still exploring, right? Even as part of this exercise, to think through, what are the members' preferences? How would they like to be contacted? How would they like to access care? How do we best engage? And I think, Jeff had some really great things to offer, in thinking about those solutions, right? Is there a way in thinking about being creative that this is presented and you might not even recognize, that this is connecting me to care services or resources that I need. So yeah, so I think in, kind of thinking through some of those challenges, it's an and, right? So working through those challenges and, as a component of that, identifying how best to engage with the family units and what are their preferences, what are bringing them the best experience.
Great, thank you. Dennis, I see your question. I'm going to skip over it now as that's quite detailed and we may need to just take that offline. So I'm going to move on to Shannon's question. How many community resource centers and community partners does IEHP have? Is it fairly well spread out over the counties, or are there a lot of blank spots on the map? Resource centers and community partners. Do you know if your members have any large employers in common? Well, I think we can answer that second part pretty quickly.
For community-based?
No, if your members have any large employers in common, I think this is probably an understanding that this is not employee-based coverage.
Oh, right.
This is largely, this is a Medicaid population. And so they have to meet certain, Tara, why don't you explain so that people have an understanding of, the kind of what we make, many people may be more familiar with the commercial coverage, especially through large employers versus Medicaid coverage.
Right. So Medicaid is a federally funded program. And so there are income requirements that families, individuals must meet to be able to qualify for that specific coverage. And so many of our members qualify for a low income subsidy. And so Jeff, I don't know if there's anything else you want to add to that.
No, just maybe just as we get into maybe just the other part of the question might be something to touch on in terms of our community resources and our health navigators and the folks that support our membership through both those community resource centers, as well as connecting them to community care.
Yes. So we have so is it okay, Kat, to transition to that second part?
Please do. Yeah.
So we have a very robust health navigator team here internally at IEHP. And they do support, through home visits. They do a lot of school-based support. And as far as community resource centers, currently we have 3. We have one in San Bernardino, one in Riverside, the city of San Bernardino, the city of Riverside, and then we have one in the high desert area, which for those of you that are familiar with Southern California, it's in Victorville. So those are, placed in some hotspots, I would say, where, we often see, accessing care maybe isn't occurring as frequently in other areas. And I would also say one of the reasons why we probably identify them as hotspots is because they are more populous areas, right? So it makes sense that we're going to kind of see those areas emerge as, less accessing some of those services a little bit less because there are more individuals that live in those areas. And then, we also have our community health worker program, which is another way to support families. So we're getting that ramped up, but it is another way, right, again, that we can help connect families to resources. As far as specific community-based organizations that we engage with, I don't have a specific count. I know that we have a large footprint in our communities throughout the Inland Empire, San Bernardino, and Riverside. So it would be hard to think of probably a community-based organization that somehow we're not supporting or collaborating with in some way. And so again, that's something we can kind of take back to some of our community teams and see if there's a specific number. I don't know if we have that exactly, but I do know there's a lot of work that happens in that space.
Yeah, I mean, what the teams use, they use different resources within the community that are in certain directories, but also one of the biggest directories is the findhelp.org and the Aunt Bertha network that the health navigators and community resource support teams use to find resources in a particular zip code or a particular area. And they have, thousands of resources within, different areas, and you can use that to find where that is.
And then a follow-on question to that, and this came up, I think, in our last webinar as well. Terry, you mentioned direct contracting with providers, and that to what extent have those providers partnered with IEHP around some of the engagement initiatives that we talked about?
Yeah, so I mean, we wouldn't have an exact number, and like most activities, you have it's on a scale, right? So it really depends on what's happening in each individual provider office. And so, I think that would be hard to say specifically. What I would say again about our IEHP internal teams is we have a great provider services team. So we have provider service representatives that are assigned to those individual provider offices. They're out there, they're meeting with those providers, they're talking to them about some of these engagement opportunities. And so as far as messaging, if a provider is, depending on their level of interest, we're able to partner with them in the capacity that meets their needs. And then for those providers maybe that have a little less interest, we keep sharing the message, right, to work on that piece. So
understood. Right. You can there's only so much you can do in that case. All right, we had time for a couple more. This may be another one that we need to kind of go back and find some numbers if available, but approximately for Medi-Cal population, what is the average ratio number of patients or members to an IEHP case manager? What percentage or number of these Medicaid patients are also part of Medicare Advantage?
yeah, so great question. I'm not certain of the ratio. So that is one we would have to take back if there was some interest in that detail. I would say our duals population, because we do have a population that is both Medicare and Medicaid, and we are a little over 30,000. Jeff, I don't know if you have a more specific number. It's like 30. 2-ish, I think. And so that's the portion, right, of Medicare duals, Medicare and Medicaid out of that 1.6.
Right. It's roughly 2% of overall membership.
Great. Thank you for that. Going through. Yeah, and Dr. Moyo, yes, if you could just provide them all through the chat. Any other questions that you have? I think we answered. Oh, sorry, one more. Do you currently use telehealth, and how are members accessing that? I'm not sure, maybe as an engagement strategy for family units.
Yeah, I can maybe answer that unless you want to take that on, Tara.
Yeah, go ahead.
Okay. Yeah. So the first part of the question around telehealth. So we do have telehealth services through different avenues. One is through a provider network and the telemedicine services that they provide for either PCP, urgent, or behavioral health services, along with access to through our digital means, like through our portal, and our nurse line capabilities also include an escalation to telemedicine services from the IEHP side. I mean, we're always looking at ways to improve adoption, engagement, access to care on all of those avenues. So we're looking right now to determine what are the best strategies to expand that, both from different types of service, whether it's additional primary or preventive, including behavioral, to augment the current network, or also to add it to different modalities and different digital front doors, such as self-scheduling, other industry practices that exist today in other spaces. So we're currently looking at that. To your other question around CalAIM, yes, we have several initiatives, and Tara, you can probably speak to this more directly, but around the guidelines of population health and a lot of the work that's being done to improve both population health equity, the data sharing, et cetera. We're working very closely with the teams at the state.
Yes, absolutely. And I think the benefit that we mentioned earlier too for our community health worker is, part of those CalAIM initiatives. And I'm sorry, I didn't see the question in the chat. I don't know if there was specific information that you wanted more details on to expand on that.
No,
For
not
CalAIM?
on, yeah, no, not on that one. And I
Okay.
think we're at time, but if we have a moment, there was just a question around what are you doing around health education? And this kind of came up a couple of times around helping families understand the need and the benefits of preventative care and chronic disease management. If that was a potential hurdle in accessing care. And so, yeah, if we can just answer that one real quick, and then unfortunately, we're not going to be able to get to a couple of the other ones that just came in, but I think the one around health education may be relevant from an engagement strategy perspective.
Yeah, so again, we have a great health education team here internally at IEHP that works to develop curriculum, across the spectrum, all the way from early childhood, prenatal, postpartum, chronic condition management, adult cancer screenings and preventive wellness. And, we have several courses or classes, I guess I should say, that are offered at some of those community resource centers that we mentioned, right? So members can go on site and get that information firsthand, one-on-one, face-to-face. from some of our health education specialists. We also offer some of that information remotely. We have some online offerings. So the information is there. So again, I think it's just trying to think through, are we getting it in the hands of the right individuals, right? Are we making it available? Are we messaging it in the right way? Especially when you think about, again, going back to that family unit versus very, very individualistic type touches or outreaches. And some of that, again, health education would be provided through some of the other initiatives that we have through either texting campaigns, or maybe it's a telephonic outreach. So texting, sometimes we'll do like the little bit.ly link where it pops open and directs them to an area where they can get more information. So definitely lots of activity around health education.
Great. Thank you so much, Tara and Jeff. I know we were over by a couple of minutes. Appreciate your time this morning. I think the folks on this webinar have received a lot of really valuable information related to not just this category of family unit care, but I think probably more broadly across IEHP and maybe applicable to some of the other challenges as well. So India, I know there's a couple of kind of housekeeping items around how to access the information that everyone needs. I will hand it back over to you. And thank you everyone for your time.
Awesome. Thank you, Kat, for leading an engaging conversation, and Tara and Jeff for your insights. Just real quick, for those of you still on with us, I left a few very important direct links and resources in the chat. Just to go over those briefly, the first is the IEHP Innovation Challenge website. That's where you would go to sign up for the challenge if you have not done so already. Also, if you scroll kind of midway through the landing page there, you'll see the activity timeline, and that's where you can find links to the 3 previous webinars. And within the next 24 hours, this webinar recording will be posted there as well. As Kat referenced, there are a series of assessments that need to be completed to have a fully complete submission for this challenge. There's a link to directly log in and complete those assessments if you have already started the process, and we encourage you to do so as soon as possible because submissions close next week on August 17th at 5 o'clock Pacific Standard Time. If you have any questions, if you visit the challenge website, there's also an FAQ for anything more general, but if there are specific questions you run into as you're completing your submission, please feel free to email us. contact@scalehealth.com is a great way to get in touch. So with that, Jeff, Tara, any final words to close us out?
Just so thank you and appreciate all your support, both Scale Health as well as everyone on the call. And we really look forward to reviewing all of your ideas.
Yes, definitely. Just echo what Jeff just said. So just very excited to see all the ideas that flow in. Thank you.
Awesome.
Thanks, everyone.
Thanks for joining,
everyone.
everyone.